And we're getting into a health conversation this hour. If you're just joining us, we will look into the intrigues of what's going on. It's a big month for health. Universal health coverage will be launched this month, and the government preparing, cleaning all the silverware, removing all the bells and whistles to have this done. Our guest for the hour is Dr. Davji Atellah, who is the Secretary General and the National President of the KMPDU, which is the Kenya Medical Practitioners, Pharmacists, Dentists Board. Thank you for being here this morning.
Thank you, Isaac. KMPDU Union.
Union, right. Sorry, I said board, union. Yeah. There are very many letters in that acronym and everything means something. We end with union, KMPDU Union. Welcome also to our audiences on KT and Home. Thank you for being here this morning. Many things in our heads, and I guess that comes out when we speak of them. Karibu Daktari. And as we get into that conversation this morning, as we normally do, Siti will welcome you with today's proverb.
Yes. Proverbs for the whole of this week come from the country of Uganda. A bad man does not lack qualities which are pleasing to him.
A bad man does not lack qualities which are pleasing to him.
He looks at himself in the mirror.
Yes.
Says, I'm actually a wonderful person. So all these naysayers who think that I'm a bad person.
Yes.
Anyhow.
I
am a good person, and I know because I can see the person. And why can I see the person? Because I am the person.
What do you think about that, Daktari?
Yeah, you see, essentially, it means that you cannot see the faults that you're having. It's somebody else that can see them. In a great extent, you always believe that you're correct and you're right in the things you say, even the things you promise as a person. Because in yourself, by the time you are promising them, you think they've already been done. So I think that Proverbs will resonate in that particular manner. Yes,
indeed. There's always a fault somewhere.
Shouldn't
you be the first one to see it? Essentially,
no, I think the good doctor is right. The one thing that we cannot do very well as human beings is see ourselves with the clarity that is necessary.
Yeah.
We always tend to look at ourselves with a kind eye.
Yeah.
Yes, we even apportion qualities we don't have to ourselves. Okay.
Interesting.
So,
Looking at qualities, the union has always, even as we get into this, the union has always fought for, lobbied for the rights of medical practitioners as well as the institution of proper healthcare mechanisms in the country. And as the Kenya Medical Practitioners, Pharmacists, Dentists Union, Daktari, you now sitting at the helm, give us an overview of what is currently happening with the health situation. We did see a couple of weeks ago where you talked about, look, things are not working as they ought to. We're not hiring enough medical practitioners, again, which has been an issue. We're not paying them as we should. We don't have enough to go around the country. Give us an overview of what's currently happening and what the agitation is as of today.
I'll first say by this, it's quite a philosophy that has been talked about all the time, that there's a lot of promise, there's a lot of hope that every Kenyan has during the political campaigns and when political leaders really want office. And when also they come to office, and I think with this government, there's a lot of promises they're giving. But there's a philosophy that says that the road to hell is built with good intentions. And this summarizes the story about the UHC that we keep on having a conversation on. And if we look at it and to say that, are we able to achieve universal health as a country? And I say it every day, that it has become a political rhetoric, or rather a pipe dream for us in a country, and we may not see it anytime soon. Why am I saying this? Is because as a country, we have specialized in handling healthcare in silos, or rather in quite different departments and different sectors. We try to look at healthcare in terms of the primary healthcare on itself. We try to look at healthcare in the specialized service provision alone, public healthcare alone. And that has brought a lot of inefficiency in delivery across the country. And what has this resulted in? If we go down to the hospitals today, there are a lot of, I will say, deaths that are occurring that actually are very preventable. And why are these things occurring? Because number one, we have a health workforce that is, I would say, limited health workforce. Doctors are not being employed, and for the last 6 years, we have had the highest number of unemployment that has never been seen before. While this is happening, there's the biggest shortage in the hospitals. You will go there and you won't get care. This happens the same to the nurses, this is the same to the clinical officers, this is the same to the lab workers. We have at a time that the hospitals are understocked by the medical, by drugs and the medical equipment. So you will go to the hospital, you are lucky to see a doctor, you won't be able to get the drug, you won't be able to have the reagents. That is a reality.
Dr. Atellah, I need to stop you there and say, look, when we're in conversation sometimes and we run the risk of trying to sound, sensational sometimes. But are we saying truly that this is the situation? That you go to hospital today in many parts of the country, truly, and that you cannot be seen by a doctor because they don't exist? You cannot get the medicine that you require because facilities are understocked? Is that the true picture? That we are not getting adequate resources to deliver healthcare around the country? Is that the case for real?
This is the truest picture because, you see, when we talk about doctors, they do not just serve themselves, they serve patients. And we have, like a month ago, I've been speaking about this a lot. The doctors, the gynecologists who work in Kakamega County Referral Hospitals had to give a letter to the chief executive officer and to the county and close down the hospital and that department. Why? Because they did not have reagents. There were no reagents, there were no drugs to actually have emergency services in those particular hospitals. So they're actually trying to choose which patient to serve at a particular time. Last 2 weeks ago, Nakuru doctors went on strike. Why? Because the hospitals was writing to the workers that the drugs that they will need were out of stock. The reagents are not, the particular request for requisitions, the lab cannot be done. So these are realities. The same situation was also in Embu. And these are practical occurrences. Even if I go further, even to look at the indicators and even the maternal mortalities, we have had cases whereby, I think it was from Central, where a mother could not get an ICU care. He had to be transferred to Nairobi. When he reached KUTRH, he didn't have the money to put the deposit. So he had to be seen in Kenyatta National Hospital. But before he was seen, he had to close the baby. So these are realities. Sometimes they're not coming out in media and people are not seeing them. But if you visit the hospital today, you will see. We had a report that was done, I think, in the year 2022, I think about September, where the hospital visits, what's the number of the public that will go to the Kenyans who go to public hospitals? It was realized that about 72% will go. But then those who will get care, less than 50% will get the care they need. Because you have to wait in the line for about 10 to 15 hours to see the doctor. Once you see the doctor, you are not sure whether the reagents will be there in the hospitals. You'll be told to go to the lab outside the hospital. And if you get back you prescribe for drugs, you go to the pharmacy, there are no drugs there. That is the reality. If you have a procedure, you'll be scheduled 3 months down the line. And why is that happening? Because there are no equipment in those hospitals. The theaters are not working. So that it's a reality that happens. And this has gone to a greater extent that, and it's quite expected. Why is it expected? Because you can come down to look at in the year 2016, 2017, 18, 19, 21, 20, 23, how many doctors have been employed across the 47 counties? How many nurses have been employed? How many clinicals have been employed? How many have retired? How many have died? How many have actually resigned because of the frustrations and left the country? And these are specialized doctors and also all the good specialized nurses. You'll quite a big number of them. Are they being replaced? No. What then happens to those populations, to those people who are actually taking care of those facilities? Yes.
So, from the point of view whereby the representation of medical practitioners then falls under the union, what do you think is the problem? What is the reason behind this lack of facility, the lack of human resource, the lack of medical treatment and services? What is causing that problem? Because it can't just be a money problem.
It is both, really. You see, even the Bible says money can give you everything. If you don't put money into something, you can't expect it to happen. You can't expect services. Actually, healthcare cannot be free. Somebody has to spend for healthcare services to be provided. It's either the government invests so that healthcare is realized, or the individuals must then use the out-of-pocket to get to seek care. Probably the private facilities that are investments. So that's one thing. The first solid thing is that are we as a country investing in healthcare? And this brings down to now look at the counties. When we say that counties are not employed, what do counties say? In 2017, the then Council of Governors chairperson, Honorable Ngwai, said that they need over 80,000 doctors across the 47 counties to reach the WHO ratio of 1 to 1,000.
At that time?
At that time.
Yes.
Yes.
Okay.
But from that time to date, they've only employed 1,000. That is
against the 10,000.
Against the 80,000 needed.
80,000,
yes. And from that time to date, we've had about 5,000 graduating, meaning we have about 4,000 unemployed when we need about 80,000.
No, it's not 4,000. It's more.
It's more.
It's more.
Yeah. So then, when you ask the counties, that same statement that was used in 2016 to resonate, they say that according to the PFM, Public Finance Management Act, which says that they can have the recurrent expenditure of 35% on wages and salaries, that about, from the report of the Control of Budget, 46 counties have exceeded that, except Kwale and Tana River and Mandera. The rest have existed. So they say they can't employ. For example, Mombasa County, we had a discussion with the governor. He says he can't employ. So what is he planning to do? To commercialize the county referral hospital, to remove it from being a county referral hospital to being a county corporation. Why? So that it doesn't depend on these finances. He can now borrow and from on the side. And you see that, in essence, will relieve the county, but it will burden the community. Why? Because for an hospital to run on itself as a commercialized entity, then it has to charge more, just like Nairobi Hospital.
So, Dr. Do I hear you to be saying that, in essence, when we pay our taxes and the government superintends it, should the government allocate more money to healthcare?
Essentially, yes. And that's why Kenya is one of the countries that signed this Abuja Declaration. And you see, one thing that this thing was looking at, it was saying that 15% of the annual budget should go to healthcare, or 5% of the GDP. Then the elements of healthcare had to be looked into in total. We do not look only at the infrastructure, the facilities, or the hospitals that are being built across the country. We have to look at health workforce. Do we have the mixed skills to actually make hospitals operational? Do we have commodities and equipments that then can support these service deliveries? Do we have good governance and leadership within those particular hospitals and the counties? Do we have service delivery? Those are the elements that this particular budget money will go to. But how much do we budget as a country? This year, I think our budget has even gone down. It's about 5.5%. Last year, it was 4.4%. In fact, if you look at the budget that we've had for UHC alone, in that total budget for healthcare, in 2021-22, we had 67 billion. 2022-23, we had about 47 billion. This year, for UHC in the health budget is about 18.3. So it means that as much as the country is really looking towards attaining universal health care, the finance for it has not been put in place. They're probably expecting to collect money later for the same years.
Okay. You painted a picture that seems, pretty grim, about what's going on with the health situation around the country. Are there examples? Are there models? Because health is devolved, that we understand, right? Are there models around the country, counties, where it is working, where adequate supply is met at medical facilities, people can go in, get what they need, be treated, receive treatment, and then go on their merry way? Is this happening anywhere in the country today?
It's just been quite a bit of a subjective issue, and there are a lot of PR and public relations that each and every county tend to play particularly when governors are in the campaign mood, and then when they get into the office, they try to really put the agenda of healthcare to be the priority that they have. Because you see, you can never, I always say that you can never play PR for healthcare for a long time, because essentially people will die, people will lose their lives if it doesn't work. So for quite a number of time, for a long time, McQueen was working, and there was that discussions and that preparation on it. I think a few years, 2021, 2022, Nakuru, they had very promising indicators, because even the maternal mortality had reduced. Nairobi during the NMS, there was actually an improvement. We also saw facilities being, many of the infrastructures being built up. We saw the biggest number of doctors being employed, number of nurses. I mean, there was health workforce. But that changes depending on within a particular time. Even Oma Bay County, we saw before this new government, it's actually a deathbed during ICU. We are seeing now more improvement, and I'll say there are little milestones that occur, but they don't translate to actual service delivery that can be actually ascertained to. Even in Kisumu, I must appreciate the fact that the governor of that hospital of Kisumu received care in Jaramogi Oginga. But you see, there was a lot of preparation
around that
before he gets the care in that particular place. If you walk there now, me or you or anybody else, will you get the care in that particular scenario? To the point that some doctors had to be brought in to assist. So essentially, what the type of the hospital at the point it was getting care, that's how hospital should operate every day, not only the time when it's getting care there. So I will say, as it is now, what has really come out very glaringly and a great thing from the devolution is the infrastructures, building the hospitals across the country. They have done it, they have built it. But in terms of the service delivery, there's a problem. And why am I saying that? Even today, governors who KEMSA billions of money. It means that the drug flow into the hospitals is hampered to a great extent. That they have to keep on going, sitting down to have payment agreements, which again they default and make drugs very difficult to flow there. The government promised to restructure that, but it has not been done, I think. Now it's not been done.
Not yet.
We have the issue of the health workforce. I can tell you that in the last 1 year, for example, only 40 doctors have been employed across the country. Yes. And for the last 1 year, only 40, yes. And the county that employed the lion's share is Bungoma. It means that all these other counties have not seen to it that there needs to be a change. When you look at also, when you skip on, there's a lot of inequality in the service delivery across the country. And this is very clearly illustrated by the indicators. We have maternal mortality, for example, in as Kenya, we had 414 per 100,000 live births, which is double the world average. But with that 414, Mandera has 3,800 deaths per 100,000. It then means that if you say that the devolution has worked as expected, that indicator has not reduced. Turkana has 1,800. Wajir has 1,700.
Dr. These deaths that we're talking about, 3,800, 1,400 against 100,000, what deaths are we looking at here? This is not maternal mortality.
It means that...
This is not maternal mortality, though.
It is.
So we are saying that Kenya, the numbers that have been collected over time, 414, because we had a conversation about this just a couple of weeks ago. And yes, we're looking at about 400 deaths per 100,000, right?
Yeah.
But what you're saying is that the truth on the ground is that there's some counties who, as a county alone, are surpassing what this national statistic is saying.
And I'm telling you, like Mandera is 3,800 per 100,000 live births. Wajira is 1,700, like Turkana is 1,800, and the coastal and Nyanza counties are up to about double the national average. So it means, yes, as much as we talk about this devolution has worked things, but is it reflecting in these indicators? We have cholera outbreak the other time here in July. It's 2023, but we had about 200 Kenyans lose their life because of cholera. What does that really indicate? So those are the things that we need to look at in clear terms. How many Kenyans will go to these public hospitals in level 2, 3, and 4 and end up in Kenyatta? When, for example, you have a cancer, you go to the hospital several times because there are no specialized oncologists, there are no specialized doctors to actually identify these cases early. By the time you reach Moi Teaching Referral Hospital or Kenyatta Hospital to see these to get specialized care, you are in stage 4. How many people lose their life in that scenario? If we had a functional healthcare system where these things are looked in tandem, we are looking at the screening, we are looking at the referral system, we have a high diagnosis of this, there will be change. And I keep on saying, why is it that we normalize death as a country, whereby somebody has died in Kagan or somebody has died in Mombasa or wherever, then the community says, no, its time has reached. It is, and this could be a complication of either hypertension or either diabetes or any of these complications. And most of the time, if the same person was living in a place where there's a functional healthcare, let's say in UK or wherever, they will not be died by that time. So those are the realities you have to look into. And what makes that difference is that these hospitals are functional. You go to those hospitals, find the doctors. You know, a mother, with the social inequalities that we have as a country, somebody going to the hospital and spending 15 hours, it means that they've lost the income for the day. They're probably going to sleep hungry that day. If you tell them to go back the next day to wait for that 15 hours, they'll rather not go.
They wouldn't do it.
Yeah, they'll go try to look for money to actually feed the families first before they try to go. So those are the burden that also comes up in the country.
Dr. let me ask you something. When you look at the situation that we have in the country, from what I hear you say, that the health care situation is worsening. It's getting worse.
Yep.
And you are saying that by the time we hear healthcare workers planning or talking about taking industrial action, it's not because of just pay. It's because they cannot adequately perform the tasks that they're employed to perform, because they do not have the capacity in terms of commodities, in terms of equipment, in terms of everything that would make their work possible. 1, 2, you're also saying that every time the government talks about improving the healthcare system, it is simply talk, that nothing actually happens. Is that what you're saying?
Yes.
Oh, I see. No elaboration, just yes. Okay. Now, then, am I then to conclude that we are staring at a situation of total collapse of our healthcare system? Or are we still far away from it?
You know, I said yes, because there are the quite things that has to be done to make healthcare work.
What are these things that have to be done?
We must, you know, as a country, we are looking at healthcare as more of a recurrent expenditure. We have not come to this point to realize that healthcare has to be an investment, whereby when you employ health workers, when you make the hospital operational, then there's a lot of, actually, the WHO Investment Charter 2023 indicates that if you invest $1 in health workforce, in healthcare, you reap actually $9 in the economy. Why? Because, for example, if an hospital set up and you have doctors there, if a patient comes, the payments are being done in this hospital, even by the insurance, whether it's a NHIF or any insurance. So from the consultations to the lab, to the drugs, to even the procedures. So if these hospitals were functional, then they can support themselves to actually run. But the situation that is in there is that they are not functional, and the deliberate approach is make them not to function. That's one. Number two, as we speak today, we have this national hospital, NHIF.
Yes.
The government owes NHIF 22 billion as of today.
22 billion.
22 billion. And this is billion from services that have delivered to both public and private hospitals. So it means that if you are going to seek care in this private hospital now, and probably you have only covered for NHIF, the chance of you receiving this care is actually is lower. So it means you have to go out of pocket to get this care. The other time, the police, and this is another thing, the government is talking about the finances to have healthcare. They removed police from NHIF, which is public,
yes,
to private. And I'm telling you, this is just because of kickbacks.
Okay. Coming off the back of universal healthcare, it will be launched this month, now properly, right? And according to what we're being told, there are many plans in place. It seems a little bit foreboding, though, with some of the things that you've said. And as we went to the break, just giving some insight into what is really happening with NHIF, which, again, is the driver for UHC. Now, of course, we've been told that there will be different levels whereby you'll be able to access healthcare with the new UHC, with NHIF being split into 3 levels. Certain things will happen. But you seem to have an issue here and saying the way NHIF currently is operating, owed money everywhere, not operating properly. Sometimes you go with your card, it doesn't operate. How will then UHC be delivered on this 3-legged horse?
And that's what we're saying, and we kept saying it, and that's UHC is a pipe dream. And I want to remind you,
launching this month. How can it be a pipe dream?
The doctor is telling us we're launching a pipe dream.
It's being launched this month.
And see, this is not the first time it's being launched. UHC was launched in this country in 2017. We had what do you call the pilot counties that took that gave out there was inputs and output and gave out recommendations,
and we launched them in those counties.
Yeah, they launched them in those counties. We also launched it nationally for the UHC, and in fact the budgets have been there for it. But I can tell you honestly that it's a pipe dream, because what is the vision of UHC is that every Kenyan should have an access to healthcare, regardless of your socioeconomic status, and you must have accessibility to it. That's the thing about it. Even if you are a farmer or whatever you are, you should be able to go to the hospital and get quality healthcare. But how will that happen if we do not look at the fundamental blocks that will make healthcare accessible? I know there is a very big confusion in terms of the primary health care that is being talked about every day and the bills on it, and the universal health care. And just to make it easier for you, I think the government is driving more donor agenda than the agenda they want to achieve by the universal health care, because it is a discussion that was there in the World Health Assembly this year. It was a very big conversation in the United Nations General Assembly. In New York. It's a big conversation. And even the government's UHC project with the community health element actually is a donor-funded project. So there's a big more of an interest in pleasing the donors than in service delivery in itself. Because what we kept on saying is the aspect of having community health promoters bad? No, it's good. Why are we saying that? Because the community health promoters essentially is to sensitize the community. It brings about the social aspect of healthcare. That it should not be just an issue of the doctor, the hospital thing. Let's understand it from the point that you know that you are sick, you need to go to the hospital, you know that you have hypertension, you should be taking your drugs. Because even these the BP machines and the strips for diabetes, individuals actually test themselves at home. They check, and so when you have the community health promoters to it means it's just easy to confirm and to check all this. But from this point, it talks that once this is done with the households that you're given as a community health promoters, you need to refer these people to level 2 hospital. And let's call it the hub and spoke.
Yep.
Then from level 2, then they can now be transferred to the level 4.
Yes.
But the level 2 is dysfunctional.
But we've been told, look, I mean, Daktari, the gentleman who's driving this from the government level, and just, he told us very clearly that the fund that will deliver healthcare at that level, below level 2, so you're to that 1 and 2, there's a different pool of resources that make sure that happens. As you get onto where you need to be referred to for, more detailed health care, then there is another pool of funds that has been created for that. At the highest level, whereby you need a more severe or more serious medical intervention, that is where now you have a lot of donor support, you have a lot of private funding coming into that to take care of that. So it would seem as though they have a plan in place in terms of where this is all going to come from, because at that basic level where you go in and you have, a fever that can be tested at the lab, etc., government funding will take care of that with your card. As you then graduate, if you need to be referred for something else, there is a pool that has already been set aside and demarcated. So it would appear as though that these things that you're talking about have been considered, and that is why they've come up with this mechanism whereby it will guarantee that whatever level of healthcare you seek, it will be taken care of. What would be your problem with that?
These things are more theories than practicals. And sometimes theorizing issues is very easy, and you can even theorize your way to heaven if you are a religious person, and you see yourself going there. But the reality is quite different. When you talk about the aspect of this healthcare and the universal and the access to it, and you say, we are going to have, and it's actually the opposite. The part of these. Currently, the part of these primary healthcare and all that's what's more funded. There's more donor-driven, because it's not only in Kenya. In fact, this issue of community health, I think in Malawi they call it community health workers. In Zambia also, it's actually a project that's driven globally. But the point is this: yes, first of all, I'll keep saying that it's more of exploitation to these community promoters. That's another story, though, because you see, you're being told that you're going to have 100 households, that you need to go and move into each of them and identify the conditions and advise them all this. But the locations that they are in, with the 5,000 that you probably be given, will make you a beggar in those particular households. and you won't be able to reach even to have. So ideally, government need to employ and empower people with the minimum wage bracket, rather than saying that we're going to just put you there to promote. That's on the side. But now the reality,
the model that they've taken, comes from the community health strategy that was implemented in around 2012.
Yes.
And then the stipend which was being given for volunteers was 2,000 shillings.
Yes.
But the areas that they were covering was the areas that they came from.
Yes.
And in many of these instances, you had what they called a community unit that had been set up. And part of what they were provided for were things like bicycles.
Yes.
So traveling was not an impediment.
Yes.
Okay? There was a whole ecosystem set up to make sure that these things were possible. Now, when you're now putting it into practice in this modern day from 2012 up now, you're talking about 10 years down the line, 11 years down the line. The realities now are very different from when the proof of this particular concept was set in motion in 2012. So, for it to work and for it to work effectively, beyond the gadgets that they brought in, which are a huge plus and a wonderful thing, the remuneration that these individuals actually need to be able to do what they're supposed to do effectively goes beyond money. Now that discussion is not being had.
Yes.
And we're saying at this point that in order to deliver this primary health care at the levels of, 1 and 2, that needs to be put in place.
Yes.
And if it is not, then we're just going back into the situation where we currently are, whereby you can't diagnose certain things, you can't look at preventative care if you're not looking at, basic diagnostics, for example.
And what is strange about what the community health strategy proved? When effected, it reduces hospital attendance by colossal degrees. But you have to do it carefully and you have to fund it properly. And if you do, it costs so much less than this curative approach that we have. It is mind-boggling.
But surely, Dr. it is doctors, it is medical professionals, it is medical practitioners who are lending to this conversation about the development of UHC. It is not journalist Ndu who is talking about what you need to do for UHC. It is people who are versed in the knowledge and understanding of the medical profession. So why would they get it so wrong, according to you? It would seem as if they would know what they were doing when they said, let us use this model. Or is that not a prerequisite for having a functioning health coverage system?
Sometimes in political dispensations, you have interest, you must want to do something, but at the same time you get impeded by the political will. And I must bring this, if I look at the manifesto for Kenya Kwanza, the baseline to start all these issues was that they will employ 20,000 health workforce within 100 days. And we are down to 1 year, and there is none that you can call has been employed. That's a reality. There is a promise that was given that because there's an existing political interference between the national government and the county government regarding the healthcare delivery. In fact, even this primary healthcare has been quite politicized by the counties. In the constitution, it's the role of the county government. In the national, they also have a role to play because the sufferings have never been devolved. Deaths are not devolved. Every Kenyan is a Kenyan.
Right.
But in the reality, you realize that comes back and forth. The matter of interest comes very strongly. So that promise of Health Service Commission or centralized body that will actually ensure that health workforce issues of training, promotions, employment is sorted out has failed. And the narrative that was there, that this will be sorted, has changed. And you will hear, like the executive saying, the health has really done very well in the devolved sector. And they'll say the counties are doing this. And that is purely political. Why? It's because the governor's interests have to be catered for. The governors do not want to do away with this prospect of, as much as they know that the health workers doesn't work because they don't have the money, they know it gives them, they can actually have their ghost workers there, they can actually divert funds, they can do all those funny things. And that has made the executive change the narrative that no, now health is working. So some of these things that are being done, there's a lot of political interest and political goodwill and political power properly in between.
It's a very unique profession, this medical one, because yes, there is the you want to get paid for the work that you do, sure, but I really do believe that over and above that the care of an individual who falls ill or needs some kind of intervention is is over and above everything else.
Yes.
Right? What should it look like from your point of view when we say, look, this thing has to work, that folks should be able to come into a medical facility at whatever level, 1, 2, 3, 4, 5, 6, at whatever level? What should it look like? Because we keep saying, this should not happen, this should not happen, this should not happen. Let's be prescriptive, as you normally would as medical practitioners. What should it actually look like? What should we be saying should be the very basic in terms of provision?
Actually, you've really answered yourself with the same question that, we need to go to the baseline. We need to go back to the basics. A lot of times, and I mean, it's a reality, we see many projects being launched, many policies, many plans, like the right kind of, I call it the plan, it has all these things. You have many bills that are being put into place. Every year we have health bills, we have amendments. But when these things are done, does it translate to that patient who goes to the hospital to get care? Does it translate to the having the health workforce? Does it translate to having those particular hospitals having enough beds? Does it make it possible that if you are going to the hospital, you get the drugs that you need? So the basics, and these basics actually, the WHO building blocks that are shared across, and Kenya is one of the member states of these WHO. What are these things? We just need service delivery. We just need to have enough, or rather, we try to strive to have enough health workforce. We need to employ. It can't just be put to us there. We need to have, I would say again, we need to have the commodities in the hospitals. We need to have, it's called the good governance. Basically, this is the basics. But if you look on the flip side, the bills that even are coming up now, the bill of FIF, this is pre-devolution. We had a facility improvement fund, which means that the money that are collected in that hospital actually need to be used to improve that hospital. Mm-hmm. But what has been happening is that, yes, hospitals operate. They are the biggest revenue contributors in the counties, but that funds are being directed to other things, roads, to other projects. That's one thing that happened. That's why that FIF bill, as much as some people will say it's actually a good one in the first place, when you look at the digital bill, it just needs to streamline things. But then how? If you have digitalized all the systems across the country and there are no personnel, there are no drugs, it's not functioning, how will it help? Those are things that we look into. If you look at also this, we call it social health insurance bill that has been put in place to replace NHIF. What better thing is going to do than NHIF was not doing? Because the fundamental thing that comes out of it is that it's going to increase the contribution from the normal, I think, 1.7% to 2.75%. There is now an aspect of the household where we have the 300 per household. Yeah. We know that in terms of the contributors, about 83% of it are from the informal sectors. What mechanisms will make somebody know that this person is from their informal incomes, they have 300. They can contribute 300, they can contribute 500. You see, and what is the mechanism for sustainability into that prospect? Because then if the government is trying to run the UHC by the social health insurance by that funds, what is the sustainability framework? Because we've known the default rates for NHIF has been very high because of the ability to contribute has been low. You are informal settled, you have to contribute 500. Now they've reduced to 300 for the household. Will it be possible? And that's why I keep on saying the government has to deliberately invest in healthcare. The taxes, budget part of it must be put into the budget and to make healthcare run.
An investment in healthcare doesn't mean putting up new hospital buildings.
No, it means it's not. We should not, and that's what I started with. We cannot handle healthcare in silos, where we say now we are out to ensure that we're doing primary healthcare, and these are it's called one-stop shop for healthcare. You cannot do that. Because then we have to add the aspect of the specialized care must be there. We have the aspect of the public health care. And also healthcare is not just the infrastructure aspect of it, investment. It has to be the part of also the human. You can build a 7-star healthcare facility in the country, but the high chance of it not functional is if it does have the health workforce. We know very well that we have this project that took place, I think it's still on now, the managed equipment services.
Yeah.
It was very many equipments were pushed down to the different counties. it was a good project in the sense that now there will be diagnostics, there will be ICU equipment, there are all this in different counties. But they didn't check that, is it going to be, who is going to operationalize it? Who is going to make it work? And the report that came in indicated clearly that many of those facilities end up rusting. They end up not giving service to the wananchi. Why? Because there are no personnel to run them. There were no reagents for them. This year's budget of 18.3 for the universal healthcare, 5.9 billion is for still the management services. But now, the reports that have been brought forth about it not functional, are the issues that have been there, have they been corrected? So you get that? So
exactly.
There's something I have to ask here, because when we, a while back, when we had the then chief health officer for NMS, one Dr. Luga, he painted a very interesting picture of what NMS had done in this county with regards to healthcare services and healthcare provision. He spoke of not just launching, but actually having a cadre of healthcare volunteers that had already been deployed. Now, when we had now the current governor of Nairobi in this very same studio, he cast a shadow on what Dr. Luga had said and gave the impression that a lot of it was talk, but it was not true. Now, you happen to be the chief who superintends the union functions of all medical personnel in this country. Tell me, people, from what you know and from what you see, how successful was that NMS project? The reason why I ask this is because if you're going to talk about Makueni, you are going to talk about places where you can look at success. I'm asking the question, the projects that the NMS instituted in Nairobi with regards to healthcare, would you consider them to be something that one can look at as a case study of how you can have turnkey projects in the healthcare sector to actually meet the intended needs?
I would say that the project of the NMS on healthcare actually increased access to care, because before the NMS, where will Kenyans access care in Nairobi? We will only go to Kenyatta National Hospital, and that was the only place with ICU. We only had Mama Lucy, which did not have ICU, and it was having that population of about 2 million for the Eastland. We only had Bagathi.
It didn't have an ICU.
It didn't have an ICU, but that's Bagathi used to have the hospital. Those are the public hospitals which were existing, and then the rest ones were quite distant. All the residents of Kibera, for a long time, they will access care in Bagathi. They used to call it IDH. If you need care there, you have from Katwekera, Kisumundogo, all those regions, Lindi, you'll come to IDH. Mkuru wa Jenga, all that region, they just used to be Lunga Lunga Health Center, which was more of a dispensary. So ideally, the NMS project actually constructed these facilities. So we will say that the infrastructure was there. But from that point, we have data that year, NMS employed over 120 doctors. It employed more than 200 nurses. It employed quite a number of health workforce to the county. That is, in fact, it was the highest. If you look at one unit employing health workers, in that year, NMS employed the highest number.
Yeah.
So it means that, yes, as much as these facilities were here, they also had health workforce. The commodities also are there. So we can't put it that it works 100%. There has to be challenges that exist with it.
Indeed.
Because it has to be a continuous process.
That's right.
Yes, it has to be, what I mean by this is that once things have been put up, there has to be continuous budgeting to ensure that there's continuity in the provision. It's not a one-stop.
It's not a one-stop.
And that's why I will challenge the governor one thing. He's come to the office, yes.
Yeah.
We have one prospect that is there, is that he's hiring about 123 doctors, which is a good thing. But it should not be that he's hiring this to remove, rather, to fire or dismiss the over 80 who are employed by the NMS, because that's the plan that I'm seeing there, whereby he has come into the office, he has got a pressure from probably the MCS and the team, and they feel that those who are employed by Public Service Commission are not fit to actually work in these facilities. So then they need to be replaced. In essence, you need to add up to that number so that this hospital, these NMS projects could now work better for Nairobi County.
Okay.
Yes.
Even as this agitation continues in different sectors, really trying to right the wrongs, because, I mean, according to those who practice, there are wrongs. You've talked of giving notice of strike. This has come up again. And where exactly are we with this?
I must say that we are almost 90% sure that we'll go on strike in December this year. And particularly because, when we gave a notice last year, everybody told us that we need to give government time onto the implementation of the CBA that we had that time. And it was very clear that this was a court order that needed to be implemented. And some of the agitation, the strikes we are having in Embu, Meru, in Nakuru, in Nyamira, in Kakamega, just the element of the CBA that have not been implemented, it actually can translate to strike across the country. All of these years, we have been sitting down with the government, negotiating about how to implement those things. We've had sittings from January to now. In fact, on 6th of this month, we still have a meeting. So we are not seeing headways in these particular discussions. Though, because we are patient, we have been giving government time to have this discussion. So we say, if by November, we have not had the solution to these matters, it is just right. Because there's nothing else you can do. When you go on strike, it means that's the last bullet that you can actually do. And you've given government enough time. All of these years, you've been having conversation. The other day, you saw us doing a demonstration. And to the Ministry of Health, we went to the COG, we went to the Parliament. And what were we asking for? We were not asking for money. We were just asking that the hospitals are in a bad state. There are no drugs in those hospitals. There are no equipment. There are no doctors. And those who are there are not allowed to go and leave. Employ more. And there are more than 300 doctors on the street for that purpose. We gave a petition. We expect it to be implemented. We gave a demand on the CBA. We expect them to be implemented. So if these are not done, we are saying that by November, mid-November, we will be very sure that we'll be proceeding. And it will be national. And the most important thing is that society must know, people must know, that we are going to help you relieve your burden for out-of-pocket expenditure. Because now, the out-of-pocket expenditure for healthcare in this country is about 150 billion. You go to the hospital, you must sell your land, you must leave the title deeds.
To get services.
Because you'll go to the public, you can't get it.
Dr. Davji Atellah, the conversations are wide open here. And in terms of what needs to be done, we want to thank you for being our guest this hour. And we'd like to see how this opens up. Hopefully, we won't have to go on strike. Hopefully, the ear will listen in terms of what's happening and what needs to be done for healthcare for everybody, isn't it?
Thank you.
Let's see what happens as UHC then comes through at the end of this month and how that will be launched, and hopefully we'll look into that.
This is the Situation Room, the only way to start your day.